you have the luxury of knowing what their PFT is, and you see that someone has a PFT with a 25% bronchodilator response, they're at high risk for this. Because it means that as much as they respond to it, it's as tight as they get. And so they'll have mild symptoms before the attack. They might have a specific exposure, like a bleach exposure or smoke or something like that. They're going to have very severe bronchospasm, and early bronchodilators might totally reverse them. And I may never find out about them. And if they're intubated, we often extubate them like the next day. And no one can believe it because they were so sick yesterday and today they're normal. It's just that those are the two phenotypes that we see. So there's the slow to respond, typically woman, typically poorly controlled. And then there's this young man, and it's not only men, it's typical what it is, who really never had anything that severe and comes into respiratory arrest. The young guy who got the needle was the young man. He was on albuterol, he never had anything, nothing really ever happened to him before. Okay, the decision to intubate, it's up to you. Don't wait for the ABG, don't wait for anything, do what you need to do. I mean, I need to tell you that. So, and then rising CO2, of course, is a concern, exhaustion, mental status, hemodynamic instability. Refractory hypoxemia, I don't think you're going to see that much, but not solely based on the blood gas, it's based on these clinical things. Just don't, it drives me crazy when medicine's like, well, we're going to wait to intubate because we're going to get the ABG. It's like, what are you doing? Get it after, please. All right, so here we are. Good, so I'm perfect. Initial ventilators, time-wise, not all the reason. Initial ventilator settings. Okay, so these people have high peak pressures, and you're just going to have to deal with that. You can't freak out when their peak pressures go to 80 because it's bronchospasm. Peak pressure reflects the moderate-sized airway, not the alveoli. That's why plateau is important. Do we know the difference between peak and plateau pressure? Okay, peak pressure is the highest the pressure gets when you pump the gas in. Plateau pressure is when you do an inspiratory hold and you try to measure the column of air between the alveoli and the ventilator. Just as we were talking about the expiratory hold before to measure intrinsic peak, you measure plateau pressure that way. And that's more important because that really tells you about lung compliance. And when we did the ARDS studies in the 90s and the 80s, what they found was that peak pressures aren't that important. They don't predict barotrauma, they don't predict pneumothorax, they don't predict really anything. It's the plateaus. And what asthmatics are going to have are very high peaks and relatively normal plateaus because what they're doing is they're constricting their moderate, medium-sized airways. So actually, when you get a column of air, the alveoli is okay because they don't really have a diffuse lung disease, they have an airways disease. So what you want to do is give them relatively low tidal volume, but you also want them to have a low respiratory rate, and that's the tricky part. You want to give them time to expire. Remember my graphic with the flow limitation? So you want to prolong the inspiratory phase as much as possible. You want to shorten the inspiratory time as much as possible and monitor for hyperinflation with the vent, like we talked about. So pressure control or PRVC, just so you know, PRVC is a pressure mode. What it does is you select the tidal volume and it tries to get there with pressure. It doesn't just slam in a volume. So it's a little bit subtle, right? Pressure regulated volume control. So it sounds like it's going to be a volume mode. It's not. It uses pressure to get there. That's why it dumps breaths. So PRVC is not always very good for these patients. And the reason why is the machine's too smart for its own good. What happens is it pumps in, you set it at 450, right? A nice, healthy guy. You set it at 500. And it tries to put in 500, but it hits a pressure on 40 cc's of water, and it dumps the rest of the breath, and you get 150 cc's in. So if you just tell them what to do, you don't tell them to be so smart as to try and do compliance breaths and stuff like this. You give them volume control, set a volume, or you pressure control, and you just keep cranking the pressure until you get the volumes you need. It's going to be better. You might struggle with PRVC. Now we all go to PRVC right away, because honestly for 90 to 95% of the patients, it's perfectly good. But for this patient, it doesn't work that well. So your goal minute ventilation is 8 to 10 liters, which is relatively modest. You want to keep the minute ventilation down, because that means you're keeping your respiratory rate down. Goal tidal volume is 6 to 8. So what's 6 to 8 ml per kg for me? Just let's assume that I'm 70 kilograms. I'm not. 75. Okay. What is it? 450. It's easy. Men are in the 400s, women are in the 300s, unless they're big. But guess what? Your lungs don't get big when you get big. Your lungs stay the exact same size. If I put on 200 pounds between now and 10 years from now, my tidal volumes are going to be the same. So I'm not going to breathe less because it's going to be so bad. So it's ideal body weight. It's based on height. There's a divine formula. You plug it into your little phone, or you look at it online. And I honestly don't even remember the calculation now, but it's basically 5 feet. It's a certain amount, every inch above there gives you your goal tidal volume. So your goal tidal volume is 6 to 8. So the goals. You'd like to keep your pH above 7.2 and your plateau less than 30. Peak pressures may be as high as 100. What you do, if you're in that much trouble, you've already paralyzed this patient, then you put the inspiratory hole, and you watch that 100 peak pressure come down to 20. You're like, wow, that's a lot of numbers, best. So if you have a peak plat greater than 30, this indicates decreased compliance. And in this patient, you're assessing for an pneumothorax where ET tube is not in the right place. Or they've somehow gone to pulmonary edema, have they had an MI. Something is affecting their pulmonary parenchyma in a way that is not asthma. Okay? Or we have the wrong diagnosis and they were wheezing and it never was asthma in the first place, and now we're going to figure that out. But you know, sometimes it's just not obvious. All right, so pH is less than 7.2. Increase their sedation. Okay, so you're going to do propofol, you're going to do Versed, whatever you got to do. Okay? When their blood pressure goes down, give them a bunch of volume, especially for the young person. They're oftentimes dehydrated, maybe they've been sick a couple of days, they're not eating and drinking that well, they're probably behind on volume. So give them a bunch of volume. Propofol on a young person usually doesn't rise blood pressure unless you're dry. Usually. There's some people that just don't do well with it and can't use it, but usually, so at least give them a chance with fluid. There is no evidence for bicarbonate. And that is true for almost every disease that there is, except for maybe hyperkalemia and acidosis, that's probably reasonable. But for everything else, it probably isn't. And truth be told, if you push in bicarb 3 amps in a row, you know what you just did? You gave them a crap load of CO2 to ventilate. What happens to bicarb? CO2 in water, carbonic anhydrase, all that, biochemistry. Right. And if you don't remember, just remember, bicarbonate becomes CO2, that's what it is. So what did you do? You just made your life harder. Because you made that CO2 that's 80 more, and any of their worker breathing is going to go up, and they're going to want to ventilate more. So that's not the idea. So if you have a pH that's really low and you're worried about it, like 7.0, like my lady, start them on a bicarb infusion. Because the infusion gets slowly metabolized, doesn't hugely bump up your CO2 to ventilate. That's true for renal patients too, just so you know. Renal patients do really well with bicarb infusions, not as great with pushes. So anyway, so slower infusions are usually well tolerated. You can do it as a temporizing measure until your actual real therapy starts to work. It's only to prevent cardiac dysrhythmia, that's all. Okay, running asthma. Controlled hypoventilation. Okay, so if you're not having any love with the propofol, the Versed, the fentanyl, and the Precedex, and every other thing you could possibly think of to throw on the person, just push the rock or whatever you guys like to give. Like, it doesn't matter. Just paralyze the person. You know, wear off in an hour, and oftentimes it wears off. Oftentimes it's longer than an hour. Put them on propofol and Versed and push rock, they may be paralyzed for 3-4 hours. It doesn't go away. And even if they're not, it gives them a head start, and they become more synchronous, and then the sedation is really deep, and when they come out of the paralysis, they're just better than they were when they went in. That's how we usually do it. I usually give a push, and I wait and see what happens, and when they come out of it, I wait to see if they become very dysynchronous again. If they do, I give again, and if they do it again, then I just put them on an infusion. If you're going to put them on an infusion, please put them on Invex, so I don't have to change it. That's what I'm going to put them on. I like cisatriconium. It's tissue metabolized. It doesn't matter if you're renal or hepatic or anything, and it's well studied in critical care. It's the one that we like for continuous infusion. Okay, you got to relieve the respiratory resistance. So you got to suction these patients because if they have mucus plugs, you got to get them out. Bronchoscopy is a bad idea, but suctioning is important. Prevents hypercapnia. We talked about. Look, CO2 doesn't matter. It's the pH that matters. Nothing ever happens to somebody having CO2 of 100. What happens to them is having a cardiac arrest when pH is 6.9. Okay. So vent management, talked about that. Okay. So this is just a little algorithm I put in just for whoever is going to have the thing to review it another time. It basically says what I've already said. I don't think we need to go over it anymore. Yeah, basically you go over to this part, like if you're over here with the pH greater than 7.2, everything's happy. You go over here with the P-plat is low and the pH is good, you're good. But if the P-plat is low, you can consider it high and all that, you have real pH problems, continuous to consider a bicarbonate infusion. I mean, this is 20 years old, there's nothing new in this. Actually, 20 years old. Sedation, paralysis, I talked about this. I just put in the dose for the fellows. This is how you do it. It's per kg. With cisatriconium, you can try and just push 10 milligrams, which is what's in the bottle. It's not enough for everybody. It doesn't always work. For most people, it'll paralyze them, but there are some people that it just doesn't. So if it doesn't work, it did not work. You just didn't give enough. So you actually calculate it, get it from the. I don't know if you have Invex and the Pixis in the ER, but you probably don't. You probably So you just push it around to worry about it. Heart extubation you don't have to worry about. Salvage therapy is real quick. Ketamine you guys like. And you're certified to use it. The unfortunate part is I'm not. And in the ICU, we need an anesthesiologist to sit there all night and do ketamine. It's a hospital thing. So yeah, it's not weird. So, like for instance, I'm not allowed to give propofol either, if they're not intubated. Or I mean, I can't. I'm really only certified for conscious sedation, and ketamine is more than that. Ketamine is like borderline general anesthesia. So ketamine actually has a little bit of data. It's not really robust, but it does have some bronchospastic things, or not bronchodilatory properties, and has been used pretty effectively in sinus asthmaticus, and you could consider it. General anesthesia works pretty well, but you got to get that guy with the cart to sit there all night. So, yeah. And, they won't even do an electric intubation for me, so forget it. So that's general anesthesia. Heliox. Heliox basically is a helium nitrogen mixture, and what it does, it makes laminar flow out of turbulent flow. So it kind of makes sense that it might help, right? You've got all this airways obstruction, you've got turbulent flow, that you can just make the flow more laminar, you might be able to reach the alveoli better, so theoretically it makes sense. It's supposed to decrease the work of breathing, where it's good as your upper airway obstruction. So don't forget about Heliox if you got somebody with a big upper airway obstruction. Like not this. I'm talking about someone with a tumor or somebody with some bad upper airway obstruction. You don't want to intubate, you're worried about the intubation, you know, ENT, whatever. It certainly works for that. Problem is, what you need to do is hook it up to the vent. You can't just, we gave it the wrong way to that girl. So we just hooked it up to the vent on the side. It's wrong. You're supposed to take them off oxygen from the wall and connect it to the Heliox and give them Heliox. So what I did, because I didn't know any better, was I just gave the Heliox out of desperation, and it probably helped a little bit, but it was just getting diluted by the gas I was giving with the vent. She probably was getting better on her own. I mean, Spiros, Tamidas told me, like, when I presented this to him, that she was already getting better. He came on call the next night and turned off the Heliox. So immediately. So that's that. I told her that. Non-intubated patients, you know, it can be pretty okay. But I think you should think about it in somebody with upper airways obstruction, because you'll see that. People with tumors, people with like massive abscesses or whatever, you're waiting for a drainage or something like that, and the intubation is going to be bad. You don't want to treat the person. That's the kind of person you can use it. Forget the study. I told you that. Mag, you guys love to give it. Bottom line, it's benign. Give it. Who cares? It has no data in the pulse, just so you know. And we don't really know how it works. And it works for a lot of stuff. I mean, my wife's a primary care person, and she cures somebody's chronic pain with mags. She's here. He had normal magnesium levels. I was very housebound. So he was like some fibromyalgia guy complaining to everybody. She gave him magnesium to be normal. I'm not kidding. So smooth muscle contraction, right? That's what we're taught, right? Because like, you know, it's a decreased smooth muscle contraction. That's why we give it probably for preeclampsia, and that's why we give it for kids with asthma. And I guess you guys would know better than me. I don't know anything about peds, but there is pretty decent data for kids. So it's safe. It's routinely not recommended, but if you're doing it with that young girl, I'm not going to argue with you. You give her 2-4 grams of max. It's like you pee it out anyways, nothing happens. BAL, forget it, not recommended. All you need to know, all you need to see is the last line. ECMO, the ECMO patients, so this is that from, now this is a 2009 paper. So they did a bunch of people with ECMO and asthma. Oxygenation is usually not a big problem, so ECMO is usually not a modality that needs to be done, and basically what they did was a subgroup analysis of a large group. So they did have 1,200 patients. You're going to ask me, were guys able to get 1,200 asthmatics that needed ECMO? No, they didn't. 24 of them had asthma. Okay, so you can see how few people go to that. Okay, and of course the asthmatics did well. The asthmatics do well. So like, I don't know what that means. I mean, they had shorter ECMO time. They had a higher PF ratio. They did better, but like they were comparing them to like ARDS patients, and I mean, you can't, like it's useless. And what's most important about this is there's really a high complication rate. It's like ECMO for asthma is not something that we're going to really get into, probably very much, if ever. Because look at the complications. I mean, bleeding, 25%. You know, cardiovascular, vasoactive agents they need to use 25%. This is a majorly invasive thing to do to somebody. So, yeah, I did it. Look at that, 36 minutes. I know I can do it fast. Okay. So, questions about this? It's pretty straightforward stuff, but
So, when we're looking at someone who is failing treatment because they're somnolent, how do you assess their mental status? Because I find that a lot of these patients look a little tired or kind of sleepy looking, but you go and you wake them up and they're awake.
You got a blood gas by now or no?
No.
Okay, there's one thing you can do to assess. Because you want to know,
they're not intubated.
Well, look, if you can look, are you asking are they appropriate for BiPAP? Is that the question?
No, because I'm going to put BiPAP on anyways.
Okay,
unless they're drooling and
I would say if you can easily arouse them. A sternal rub is not easily arousing them. So the fellow or the resident will come oh yeah, I can wake her up, look, and if you can call someone's name and they wake up and they're feeling a little tired but the respiratory rate's okay, I think it's more about the whole picture. So mental status is one part. But I think it's about the respiratory rate, the tidal volumes, what do they look like, are they using accessory muscles? If they're comfortable and they're laying in bed, they're now just tired, they're breathing 20 times a minute, and they're satting well on the BiPAP, I would say, okay, I think they're okay right now, and I would get a blood gas. And I would say, okay, I'll add that to the picture. I wouldn't say any of it makes the decision for you. Unfortunately, there's no easy answers to this stuff. It's clinical, and your experience will tell you in time. And you just have to see more cases and do more stuff, and you'll get it, because I think that's I think it's everything. It's the whole shebang. Look, I was taught early on, Joe Zine always told me, when in doubt, intubate. Well, extubate. It's okay. Especially a young woman with asthma, young man with asthma. That's not a blanket statement. If the guy's got metastatic cancer with mets everywhere, please don't intubate and ask questions later. Ask questions first. We're not asthmatic. Don't even ask questions. Just intubate. Because we'll save that person's life. That person's life will be saved. And this is truly where you're yeah, that's a life you really saved. And we joke around that. Right? That's what you did. Right.
If you had the choice between the propofol and ketamine infusion after they're intubated, which would you pick if you could do the ketamine?
I don't have enough experience with ketamine. I think propofol is a much more standard treatment and has probably more experience with it than asthma. So I would certainly put them on propofol definitely before ketamine. I wouldn't put them directly on ketamine, definitely not. I would put them on propofol and get them really nicely sedated and see if that does the job. And I would even go to paralytics before I went to ketamine. It's just more standard and there's more experience with it. And there's less side effects. Ketamine's good, but, you got to sedate them with that too, because you don't want them getting all crazy on the vent and whatever. And how long are you really going to give somebody ketamine? You're really going to infuse ketamine for 2 days? Certainly not. So I would definitely choose propofol and Nimbex or rock or whatever before that.
I think the data of ketamine was at the 0.3 mg per kg dose. Yeah. So it's not a sedative dose. It's a sub.
Yeah, I gotta be really honest with you, it's in the data, I wanted to put it in there, but I don't do it because I'm not certified to do it, so I didn't really dig into that much, so I'll be honest with you and say, I don't know. Look, if someone's awake, I think it's more for your non-intubated patient. If you want to do something wild to somebody and you feel ballsy one day, give it a shot, but don't do it to my patient. If they're admitted to me, please don't start ketamine. If they're your patient, you want to try, you got experience, go for it. If you've got the, testicular fortitude, as one of my mentors used to say.
All right, we're gonna wrap up. Thank you, Dr. Gorga.